Hi, everyone. Welcome to this evening's World Prematurity Day discussion. I'm Jocelyn Cohen, Vice President of Communications and Engagement with Cerebral Palsy Alliance Research Foundation, or CPAR for short. This webinar is closed caption enabled, and I'll be turning on transcription for accessibility purposes. It's being recorded, and I will send a link to all attendees and registrants once it's posted. For additional accessibility, I'll share a visual description of myself. I'm a white woman with dark brown shoulder-length hair that's down and brown eyes. I'm wearing large blue-green glasses and a textured mustard-colored long-sleeved shirt. Sometimes I might look like my eyes are looking away from the screen or rolling, but that's part of my cerebral palsy. In case this is your first webinar with us, I'd like to tell you a bit about what CPARF does. Despite being the world's most common lifelong physical disability and affecting 18 million people worldwide, cerebral palsy is one of the most underfunded conditions. And that's why we approach cerebral palsy from all angles. We find, fund, and support US-based research and technological innovations that will change what it's like to live with CP. And with broader support of the scientific process and an expanded focus on real-world implementation, CPARF will bring science to life to change what's possible for people with cerebral palsy. CP is a diverse disability that demands a diverse research portfolio, and we steadfastly support research that serves the whole community at every age and every stage. Tonight, we're focusing on the very beginning, the very first days of life. And as someone who was born nearly 3 months premature, I can't wait to learn more about the advances that have been made during my lifetime and what's ahead. I've had lots of conversations with my parents, especially since I started working at CPARF, about what they wish they knew when I was born. When things were precarious with me, they wanted hope and they wanted information. And they're not alone, because according to the World Health Organization, 15 million babies are born prematurely every year, and every family needs guidance. And tonight we have 3 distinguished panelists with us to share as much information as they can about prematurity, neonatal care, and more. Dr. Stephanie Boyd is a staff specialist neonatologist at the Grace Center for Newborn Intensive Care at the Children's Hospital at Westmead, visiting at the University of Iowa. She is also a clinical lecturer at the University of Sydney. Professor Nadia Badawi AM has devoted her professional life to the care and well-being of babies in newborn intensive care and people and families with cerebral palsy. She is an internationally recognized expert on newborn encephalopathy and cerebral palsy. She's the neonatologist and the medical co-director of the Grace Center for Newborn Care and a member of the NICUS Managers Group. She also supported the development of registers in low to middle income countries, including Bangladesh and Vietnam, and she supported the establishment of CPARF and is a member of our scientific advisory board. Dr. Beena Kamath-Rayne is currently the Vice President of Global Newborn and Child Health in the Division of Global Health and Life Support at the American Academy of Pediatrics. She has been at the AAP since August of 2019, where she works on advancing AAP training programs and technical assistance in global newborn and child health. In between her residency and fellowship training, she spent 2 years living and working abroad as a general practitioner in a clinic in rural Ecuador and as a neonatal registrar and fellow at the Children's Hospital of Westmead in Sydney, Australia. She is a member of CPARF's Scientific Advisory Board. Thank you all for taking the time out of your busy schedules to have this conversation with us. The stat I just mentioned just now shows that prematurity is a global issue. So worldwide, what factors would you say cause prematurity?
I'm happy to start, Jocelyn. I think we actually don't understand a lot of the factors because the range of premature birth is 5 to about 18% in different countries across the world. And so that tells us we really don't know a lot. We have some ideas, and it's more about the preventative strategies that have shown us. So for instance, when countries brought in prevention of smoking in public, there was an amazing side effect of dropping preterm birth rates in those countries. Interestingly, COVID, we've seen a drop in prematurity in countries like Ireland, UK, Scandinavia, because those things probably around preventing infection, less stress of women having to go to the workplace, hygiene. Then there are individual factors, and there are many of them. There are racial and ethnic differences, which we don't understand. We know that smoking is a biggie, trying to prevent smoking, having a history of preterm birth and getting proper care. And there are a whole lot of other things that we should talk about later.
Yeah, I remember reading about that COVID piece and I was shocked. I'm also a word person and not a scientist, but I was like, what is the correlation here? I can't wait to see, how the factors kind of come out.
Yeah.
And so kind of building on that, I mean, you mentioned smoking. How would you say that the factors have changed over the years?
I think people are more aware, and I think that's one of the things we all believe in, is that having parents and the community very strongly involved in what we do and having information, that's really important. I mean, when I was younger, people just smoked everywhere. You'd walk out and there'd be a haze of smoke everywhere. People smoked in cars with their children and, smoked around pregnant women. And there are unfortunately some countries where that is still happening. So I think definitely preventing smoking or smoking around pregnant women is a huge benefit to prevent prematurity.
And do you know if in the countries where smoking is still that prevalent, do they have corresponding higher prematurity rates then?
It's hard to give a good correlation because unfortunately good data is present in higher income countries.
Sure.
And data is very scarce in lower income countries.
Okay.
I think one thing that I feel like has changed is our awareness of the inequities around preterm birth that have emerged. The more that I think we do research and we stratify by those factors. I think we all know that race is a social construct. It's not a biologic construct. And so that's important to remember as we go forward and do those types of analyses. Is it likely what we're actually accounting for with those types of stratifications are systematic infrastructural issues that have exacerbated inequities related to prematurity. And just an example to build on one of Nadia's examples about COVID vaccination is that we know that because of misinformation that has been passed, it's the more highly educated people that have gotten COVID vaccinations and therefore mitigated some of that preterm birth risk associated with COVID. And so that's a risk factor that has been exacerbated by some of those inequities.
It's so true, Beena. Sorry.
No, please, Nadia, after you.
I'm just going to build on that point because in Australia, we know that First Nations Australians have double the rate of preterm birth of non-Indigenous Australians, shockingly. And one of the strategies about allowing or supporting, I should say, First Nations women birthing on country has dropped the rate of preterm birth. An amazing study by some First Nations researchers showing that if you have First Nations midwives supporting First Nations women birthing on their own country, you halve the rate of preterm birth and bring it back to the rest of the population. And I agree, that's a socio-economic and social construct. Yeah, Steph, sorry.
Not at all. I was just going to build a bit on what both you and Beena have said about the importance of the social determinants of health as they relate to preterm birth. And I mean, we know in low-income country settings, I think it's in babies born at 32 weeks or below, around half of them die as a result of what we would consider to be fairly routine supportive interventions, like providing skilled attendance at delivery, ensuring provision of warmth, support for establishment of breastfeeding, care for breathing problems and infections and medical problems that don't generally require highly sophisticated equipment to treat. And that a lot of that also is relates to access to care as well. And education, and also, I suppose, in terms of risk factors for preterm birth, we know that there are a number of social factors that are really influential there as well. You mentioned smoking, substance use, chronic diseases, but also adolescent pregnancy, and looking at family planning as a cost-effective intervention as well to reduce preterm birth. And I think a number of those social, we always think of the medical aspects, but I think, as we've highlighted, those social determinants are also really critical.
Yeah, and I think in high income countries like Australia and the US, where IVF has been so successful. I mean, if you go into a classroom in Australia now, there'll be at least one child who is born by assisted conception, and they're at very high risk of being twins or triplets because so many people put back, you know, more than one embryo to increase the success. But actually, being a multiple birth is a high risk for cerebral palsy. So putting back one embryo, which is what the Australian College of Obstetricians and Gynecologists are strongly recommending, it decreases that risk of premature birth and decreases the risk of subsequent disability.
I know quite a few twin pairs where either one or both of them have cerebral palsy and or other medical conditions. And I just remember watching as an adult where in America there were families with a lot big multiples, and I would sort of just watch the children and say, in my non-medical opinion, oh, that's sort of a CP type thing. I wonder if that kiddo is going to grow up and actually be diagnosed with CP.
Yeah, I think you're very right. It is a very strong risk factor.
You touched on this a bit, you know, how, in your experience, does prematurity and neonatal care differ by country? Is it really based on the income level? Is it based on how receptive the public is to information and how trustful the public is of medical establishments? Is all those things? Is there something I'm missing? What have you all seen around the world?
So we've seen from our work with the cerebral palsy registers in high, middle, and low-income countries, you see that in a country like Australia and the US and Europe, about nearly half of all people diagnosed with cerebral palsy will have been born before 37 weeks. And the reasons for that is that newborn intensive care in those countries is extremely successful. So the mortality rate in Australia for premature babies, like the US, is extremely low. You get to 25 weeks in Australia, you're born 25 weeks, you have an 85% chance of survival. And then if you look at low-income countries, babies under 28 weeks have a 10% chance of survival. Now, the interesting group, and I say interesting, and I don't mean that as, you know, a good thing, but it's challenging in middle-income countries where technology perhaps is a little bit misused. You see that you have better survival, but very high rates of disability. So the difference really is that I think newborn intensive care is, it's a side effect, or it's one of the things you get with affluence. So when newborn intensive care started in high income countries, there was a very high rate of disability among surviving babies. But as we get better at what we do, and we involve families more, families are our secret weapon. They have to be part of the care. Then we see the drop in the rate of disability and the severity of disability. So it's not really an income thing only. It is partly, as Beena was alluding to, the socioeconomic inequalities, but it's also the whole system. And I think one of the things I'm really enjoying is that doctors and nurses and allied health professionals, we understand now we are no longer the gatekeepers of health. Health belongs to everyone. And I think it's getting the whole community will get better outcomes.
So earlier today, the World Health Organization actually released their latest guidelines for the care of small and sick newborns. And I had the opportunity to listen in on the webinar, which was fantastic. If anyone has the opportunity to download it and listen in, and to build on what Nadia is saying, I think that for each country there are differences in what type of premature babies they're able to support. At the AAP, we have a collaborative project going on right now in Ghana with an organization called Kabeli, and working with the Ghana Health Service to do health system strengthening on their NICUs, the central NICU in Accra, and then some of their district level NICUs. And the neonatologists there will report that around their threshold of viability, which as Nadia reported, 25 weeks, 24 weeks, 23 weeks, Stephanie right now is working in Iowa. They're really pushing the envelope on threshold of viability there. But for a country like Ghana, most premature babies that are less than 28 weeks don't really survive. And if they do survive, it might not be with a very good outcome. And one of the things that we're working on with that project is implementing some of the things that were brought forth in a more standardized way in these WHO guidelines, things like CPAP, things like proper and aggressive feeding of the premature infant, immediate kangaroo mother care, which is something that I think we're becoming more and more aware of is really being helpful for the unstable baby. I think kangaroo mother care was typically used and thought to be appropriate for stable babies, but we're actually learning that this is a potential low cost, highly beneficial intervention that can decrease mortality and actually contribute towards the stability of premature babies. So it doesn't have to be costly neonatal intensive care necessarily, but things that are implemented well and done with high quality care. And then, like Nadia said, really involving parents, because we know that human resources for health and staffing of some of these NICUs, I mean, we're talking about nurse patient ratios of 15 babies to one nurse. And so really engaging the parents and letting them have access to their babies 24/7 so they can do kangaroo mother care and participate in the care of their infant will also strengthen the pathway towards going home and letting those babies survive and thrive even after discharge.
Can you tell me a little bit more about what aggressive feeding is? Because I'm thinking if a baby is so premature, do they have the ability to be fed in like bottle feeding, or are there just other ways that preemies can be fed in the NICU?
So we know that growth and nutrition is actually related to neurodevelopmental outcome afterwards. So we want to make sure, first of all, that we're recommending mother's own milk. And when we promote keeping mothers and babies together, this concept of zero separation, we're actually also encouraging mothers to breastfeed and be near their babies, or to express milk for their preterm babies that can't exactly suck, swallow, and breathe and latch on to their mothers for direct breastfeeding. And so I think in the past, because people have been so afraid of necrotizing enterocolitis, we've tended to be a lot more conservative about feeding and doing very small volumes. But I think more recent evidence shows that we can be a little bit more aggressive in trying to get those babies fed, and particularly in low and middle income countries where they may not have access to IV nutrition. And also there are infectious risk factors with putting in central lines that may remain and promote or may put those babies at higher risk for infection. We can really promote mother's own milk, feeding babies with a little bit more volume than we had traditionally been used to, and getting them to full feeds faster so that they can grow better and therefore have better neurodevelopmental outcomes.
And one
Steph,
more
what are
question
you
on that.
seeing in Iowa? I was going to ask, because that.
So it's very interesting. I think the more you go to different places, you learn that there are lots of areas of gray in neonatology, and there are things that we know work and they tend to be, accepted standard of care. And then there are areas where we really still need more research, and there may be two completely different approaches. So for example, in Japan, they have a particular approach with the very extremely preterm babies at the borderline viability that is a bit more hands-off. And then in Scandinavia, they're very particularly I think in Sweden, very keen to promote lots of early parental involvement, and that's sort of a lot building on a bit what sort of Beena has been saying. In Iowa, they offer resuscitation at 22 weeks of gestation, which is quite early compared to some places, and they have excellent outcomes. They have shown that within their own department, and this is so far unpublished data, that by trying to individualize their cardiovascular care in the first week or so after birth, they've had a significant reduction in necrotizing enterocolitis, and they have very low rates of intraventricular hemorrhage or brain bleeding, even in 22 and 23 week infants. And they have a philosophy of that's a little bit different to what I am used to in Australia, where we tend to be wanting to have babies receive their breathing support via a mask or something that's considered less invasive. In Iowa, they tend to prefer to keep the breathing tube in a little bit longer, as they've found in their patient group that they achieve greater stability in those first couple of critical weeks. And maybe some learning from that is perhaps it doesn't always matter what you do, it matters more how well you do it, and that you get very good at caring for babies in a particular way based on the best evidence that we have, and that there might be some areas where I think we need more research to definitively say that this is the right way to do this. And at the moment, I think, for example, for breathing support, there are some areas I think of gray, but they certainly have excellent outcomes in the really tiny babies in Iowa. And so it is very interesting to see how things are done here compared with in Sydney, which is where I work.
And it's interesting because actually it's going to become standard of care to resuscitate 22 and 23 weekers in Australia. It started in Victoria, it's now coming to New South Wales. And that's at parental request. So all those things that we can learn from each other, I think, are extremely important. We do have an extremely low rate of cerebral palsy in Australia. It is probably now around the lowest in the world. And the severity also is decreasing. So children who do have cerebral palsy are more likely to be mobile, have a good IQ, and less likely to have epilepsy. So they are important progresses. And I think one of the things that we have, and I'd love to hear what the two of you think about this, is we have a newborn individualized developmental care program, NIDCAP, that our nurses are pushing. Also, FI care. I think there's some evidence that family integrated care also decreases disability. There are other things that we could do. Also, a readathon. Our nurses, have started a readathon for families, a reading program for babies who are premature or sick with other conditions in the newborn intensive care, and that's spreading around the world. So there are some things that we can do that aren't strictly, I would call, medical, but they are just as important. And we are thinking more about the concept, Jocelyn, of neuropromotion, not just preventing, but actually perhaps supporting neurodevelopment.
I've not heard that word before.
I might trademark it.
Go for it. Heard it here first. Go for it. That is.
I think it's a concept I'd love to see picked up by everybody involved in the care of babies.
It sounds like that connects back to what Beena was saying also about the kangaroo care. That's where a baby is wrapped on the bare skin of their parent, right? And they feel their heartbeat and can hear their heartbeat, and they feel the warmth of that instead of an incubator.
Yes.
And so that's building sense of touch, whereas their only other touch would have been medical or the feeling of a device or something like that. But what do you mean by a readathon? Are you saying that that's to educate the staff as to the practices?
So every baby in our unit gets given a book, a bag with books in it, and the parents are encouraged to read with their baby. We have neurodevelopmental rounds where the nurses, allied health professionals, some of the doctors will do a round and discuss with parents the concept of responding to the baby's cues, trying to talk to parents about how we can promote development. The things that parents do at home with their babies, read with them, sing lullabies, trying to avoid noxious things that we do, you know, the loud noises in intensive care, bright lights, 24 hours, just trying to make things more protective and conducive to the growth of brain cells.
And I think that's a bit empowering as well, perhaps for parents who really, when you have a baby in neonatal intensive care, there's a real loss of control, and it's not how anybody expects the first days of their baby's life to go, to have a baby in intensive care. And I think empowering parents to be involved in caregiving, and even right from the beginning, in some places I know that they're able to support parents to be involved in the care of babies, and certainly that's something we encourage in our unit, is to support parents to be as involved as they would like to be, and to read to the babies, as you've said. And we know certainly that future language skills and intelligence and school performance are certainly promoted by exposure to language in early life. And if babies are spending a significant portion of their early life in the neonatal intensive care unit, it's really important, obviously, that we provide babies with those early opportunities that we would provide for newborns at home with their parents. And I think, as Beena said, the kangaroo mother care, I think, is something that is part of this newborn individualized developmental care program, and that we very much encourage kangaroo parent care in our unit. And my understanding is it has been shown to reduce mortality, even, as Beena said, in very tiny babies as small as maybe 1 kilogram at birth, that it is safe and even preferable for the babies to be cared for in the initial period after birth on their mother's chest rather than in an incubator, and we know that it improves breathing stability, heart rate stability, and for such a simple intervention and something so easy to do, which is great.
And I think I'm glad to hear other neonatologists so supportive of this, because sometimes I think we're also our own worst enemy in this, because we know that some of these premature babies, they have breathing tubes in place, they might have umbilical lines. And so really making the effort to get that first skin to skin episode to happen for mothers, I think, is really critical for them feeling like they're the parent of this baby, and critical for the baby itself, as we've come to realize through these studies that have been done, and particularly this prominent study that was published in the New England Journal in May of last year about immediate kangaroo mother care. It's really a fine line, when we're talking about the babies having these positive stimuli. In the past, there used to be kind of pods to care for preterm babies, and then we moved to private rooms. And I think we kind of realized that when babies don't have any kind of stimuli at all, that's not necessarily better. We want to make sure that babies have those positive stimuli, like their mother's reading to them and feeling that touch, and things like that. So we don't want it to go too sterile, but we also don't want it to be too noxious either.
Yeah. And again, I know we always talk about the mothers, but actually we've known from some of the research that our nurses have carried out that fathers often feel perhaps overlooked in the newborn intensive care unit. And that's where kangaroo care is such a wonderful thing. I mean, I remember one time in COVID where you could only have one parent, just when it was at the height of it in the NICU. I remember I was doing ward rounds, and there were 3 dads sitting at their baby's bedside, all practicing skin to skin and all chatting to each other. And I just thought that is such a special thing for those babies and those dads. That's got to be good for those babies' long-term outcome.
Yes, that makes me almost cry thinking about it, because I'm also just thinking back to, I was born in the early 80s, so there's leaps and bounds since then. And who could be in a place and who was allowed to touch you and all of that. I was in the NICU for 7 weeks, I think. So it's a long time. You covered a lot of what new parents should know, but what would you say are some of the top things they should know? They've now had a premature baby, and there's kind of a deluge of information, or maybe even a lack, depending on where they are and who they're with. What would you say are the top 3 things that you would share with them?
Could I go back and say, actually, for all pregnant for people looking to be pregnant, or who are pregnant.
Sure.
I think we don't tell parents enough about the risk of having a premature birth. So basically across the world, if you average it out, 1 in every 10 women is going to have a preterm birth. But most people get surprised. So if they was proper counseling during the pregnancy, they would know that getting proper antenatal care is important. Having a minimum of 8 visits, knowing what their risk is, because it is individualized. If a woman's had a preterm birth before, if she's pregnant with twins or triplets, she should be advised that she is at high risk of preterm birth. And then to be provided with information about some of the strategies that are helpful. So say a woman who has a short cervix, you know, that's the opening into the uterus. If that's short and she's having a singleton birth, we know that having a stitch or having progesterone may help prevent going into preterm labor. Magnesium sulfate is a drug that can be given to a woman going into preterm birth that will prevent disability in about at least 30% of cases. There's evidence around delayed cord clamping. So if a family are going in, about to have a preterm birth, knowing that delaying the clamping of their baby's cord for at least 60 seconds will help decrease death and disability. It's that sort of thing. I'd love us to really partner more with parents to give them the information. So that's coming into delivery. And I'm now going to hand over to either Beena or Steph for the next step.
Well, I would like to add it, you know, partnering with the parents to have all this information. I also think making sure that that transition from the fetus to the newborn. So partnering with our obstetrical colleagues as well. So Nadia mentioned magnesium sulfate, also antenatal steroids. So if a mother knows that if the OB predicts, and this is one of the issues, is that it's very difficult for the OBs to predict because there's a window of a week to within 24 hours of, or before 24 hours of the delivery happening, that if the mother is treated with 2 doses of steroids, that will help mature at least the baby's lungs. It's also neuroprotective as well. And then once the baby is born, things like caffeine for neuroprotection can be helpful as well. So those are strategies that, you know, one, it would be nice for families to know about, that they can advocate for, and also that we have good communication with our obstetrical colleagues to make sure that full spectrum of care to the mother, the fetus, and then the newborn is given.
It's really about, I guess, optimizing the health of the baby before birth, when we know that preterm birth is likely or inevitable. So things like looking at, we know we monitor growth of the baby very closely in pregnancy, particularly where there have been issues before, or where there are risk factors for growth restriction in the baby, such as high blood pressure in the mother, and that trying to work out the best time to deliver that baby. So we know that having restricted growth as a fetus does have significant implications, both as a newborn and then even sort of throughout the lifespan. So trying to better understand the role of the placenta, which I think requires more research, trying to optimize the health of the baby before birth, the things we've already discussed, like antenatal steroids. And although they were given for the lungs, was the initial reason was to try and promote the maturity of the baby's lungs before birth, we've then found later that it reduces the risk of death and disability, and we think reduces the risk of brain bleeding and other complications of prematurity. And then, you know, like we said, management of the cord at birth, and there are trials that suggest it's feasible even when there's resuscitation needed, that can be possible before clamping of the cord. And I know that there's ongoing trials in larger populations of babies to ascertain what the role of that is, but trying to work out ways to support delivery. And there even some people think maybe we should move more towards saying that we're going to support transition from fetal to newborn life rather than resuscitation, and that talking about transition is more about supporting natural processes to occur and intervening where necessary, and trying to encourage some of the physiological things that are supposed to happen to support them to happen, rather than perhaps an approach that was more based on intervention for all babies. And I think that's a sort of a difference in approach that we're beginning to embrace and understand as more research comes to light.
And one of the other things I suppose is also trying to adopt early detection. If there is going to be disability, is to try and detect it early. So one of the things that we are really promoting is the general movements assessment, Jocelyn. I know you're very interested in that videoing babies, training health professionals to take video of babies at certain times, so that if there is going to be disability, such as cerebral palsy, then we can intervene early. And with neuro promotion, trying again to take advantage of the maximal brain growth and neuroplasticity to get the best outcomes for babies and their families. And this is something parents have really taken up with alacrity. You hearing much about it, Jocelyn? And
I mean, I've heard it through my work at CPAR. You know, we hear a lot about the general movements assessment, and I was diagnosed when I was about 8 months old, and I was told my whole life that was early, right?
Yes.
Because so many children aren't diagnosed till they're a year old, year and a half, 2, 3 even. And then when I met Iona Novak when I was in Australia several years ago, I said that to her, and she said, "Would you wait 8 months to treat a stroke?" And I said, "No, I wouldn't want to wait 8 minutes to treat a stroke."
Yeah.
The idea of kind of the more time that goes by, it's like an even bigger gap than you realize when you're thinking about it. That the sooner that you can diagnose something, the sooner that you can work with the neuroplasticity like you're talking about, the better off the child will be. And that's something that's really helpful also for later in life, because someone's experience with CP changes as they age. So the better start that you give them with their CP, the better foundation they have as they're aging, like through the decades, to work with. So the GMA is really exciting. I'm happy that this organization had a part in that. And we're thrilled that it is making such a big difference around the world.
And to piggyback on that around the world statement, you know, there are some places that are looking at the feasibility of using MRI and functional MRI to also diagnose CP early, but something like the GMA is less technologically intensive. And so for the global health work that we do, we're really interested in looking at how the GMA can be applied, because in lower resource settings or low and middle income countries where there's a lack of technology, a lot of children who will eventually develop CP are diagnosed much later than they would be in places like the US or Australia. So if there's a way to implement something like the GMA and capture and predict the outcomes of those babies earlier, it also allows for earlier intervention for those babies. And we know of those disparities not only, you know, between racial groups, but also in countries that have higher resources compared to those with lower resources.
Right.
Yes, and we know from Gulam Kandakar, a colleague of mine who is working in Bangladesh, that the age of diagnosis is about 5 years. In Australia, about 50% are diagnosed after the age of 1 year. And we've launched an early diagnostic clinic, which trying to bring the age of diagnosis down for babies at high risk.
And there are a number of ongoing research trials, aren't there, Nadia,
Yes.
looking at some of these early intervention therapies and trying to work out which is the best style of therapy to provide, and that you know, early and intensive physiotherapy and occupational therapy, as Jocelyn said as well, the age at which children are exposed to therapy really can have a really beneficial impact if they're young infants, particularly in what their final motor outcomes are in childhood. And so that's, I think, really exciting that we can look at diagnosis early, intervention early, and these are interventions that parents are taught to do often, that they can do at home, activity-based interventions with their children that can improve their motor functioning. And I think that that's, you know, that really highlights the importance of that early diagnosis.
Yeah, and cognitive outcomes too. I've no doubt that reading with your baby early and singing to them and involving them in things, no doubt improves cognition as well.
I think one other piece of this is that by getting a diagnosis early, we're looking at it, of course, for the child, but that's hugely helpful for parents in giving them an answer. There are parents that go years knowing that something's wrong, can't find out what it is, or being told this is a normal delay, like again, depending on where you are and the kind of doctor you have. And so the sooner you can get a parent that answer and take away some of the uncertainty that they might be experiencing, the better for them too. Obviously, the kids with CP and people with CP are the ones experiencing it, but the parents and caregivers are also experiencing it. And it's something to be looked at. And this is something that's really helpful for them as well.
Oh, I agree, Jocelyn. 2 points. I have never, ever told a parent their child had cerebral palsy or any other disability that they didn't know already. They always know, always. And the other thing that I'm sometimes really embarrassed that some of my colleagues, I know they're well-meaning, but they will say to parents, I've heard several mothers told, oh, you're just another neurotic parent. And you know, it's meant from a place of kindness. I know that, but those mothers know, and then they're left devastated because they're left doubting their own understanding or connection with their baby. And then they're desperately seeking help. So we had this idea, or I was taught that A, I couldn't diagnose cerebral palsy before 1 to 2 years. And then B, what was the point of frightening parents since we couldn't do anything anyway? But then these parents are wandering around knowing and seeking help. So I know that all of those statements came from a good place, but I think hopefully we're moving a bit with the times.
And I think that's really excellent advice for any parent as well, isn't it, Nadia, to trust your own instincts about your baby, that parents are experts in their own baby, and that when you're seeking advice, you know, if you continue to be worried, then you should continue to listen to those instincts and seek opinions and seek care until you feel like those questions that you have been adequately answered. And that's how that's how we identify babies who, for whatever reason, are not in the system and are not diagnosed and getting therapy, is listening to parents and hearing their concerns and acting on them as well, I think, in a timely way.
And I think, Beena, I'd love to hear 2 more about your, because your global perspective too, is about the fact that we're seeing some groups where they're trying to help mothers, help other mothers, or parents help other parents in low resource settings. What do you think of that?
I mean, I think in the past, and this is something that was brought up on the WHO webinar this morning, we haven't been good about harnessing the energy of parents into the advocacy for their own babies. And I think that that's something, respectful care, family-centered care is something that is behind in being implemented in lower resource settings, because there are so many other challenges, and so I think it requires a certain level of bandwidth from the healthcare professionals to promote that and take the time to do that. And I think it's been hard when you have that ratio of 15 babies to 1 nurse. But I think there should also be a realization that actually helps with some of those staffing challenges, because when mothers are there providing care for their babies, that's also then, taking some of that workload off of staff. And, when we think about ways that NICUs actually need to be structured to promote that mothers can be there with their babies more frequently, that takes a big shift in perception of how NICUs are designed, in how we advocate with governments and ministries of health for parents to be present. And so these are discussions that we're starting to see take place because of things like the immediate KMC study, where we have to promote and advocate for even different designs of NICUs and how we staff NICUs, and knowing that KMC doesn't only need to happen in a postnatal ward, but also in a NICU. And so those are types of conversations that I see happening now more frequently.
Thank you for that. I had some questions come through, and one of them was from someone who asked, what are the odds of having a premature child again if you had one first? And I will say my sister was a month early, and then I came even more early than that. So that's my anecdotal experience, but I don't know if that's true across the board.
Look, it's a very complex question. And one of the things that actually we're learning more about is the genetic predisposition to many things. So we know that there is the big genomics push around cerebral palsy. We now have a big genomics consortium. And what I'm learning through that is that not only is there then a genomic basis for cerebral palsy in many cases, but also probably in premature birth.
Mhm.
So that's a whole area that needs to be looked at. And we know the odds are very high, which is why women who are at risk of preterm birth, who, because they've had a previous preterm baby, definitely need to get very specialized care if they're in a high income country. Beena, Steph?
Well, I know, I guess, Nadia, once in some situations, there are interventions in subsequent pregnancies that may reduce the likelihood of preterm birth. So, for example, in women who've had pregnancies complicated by preeclampsia, that administration of aspirin early in pregnancy to appropriately chosen women, depending on what their medical history is, and in discussion with their obstetric carers, that there are situations where treatments can be given in subsequent pregnancies to reduce the likelihood of preterm birth. And that also includes looking at, as you said, things like a cervical stitch when there's a singleton pregnancy and there's a high risk of preterm birth. So I think as we learn a bit more about what happened in previous pregnancies, there may be specific therapeutic targets that are available to us that we can harness to try and reduce the risk of a preterm birth, and certainly increased monitoring. So making sure that women are in a sort of high risk pregnancy setting, and that they have their antenatal visits that are appropriately spaced to recognize that they may be at a heightened risk of preterm birth, and making sure that any chronic conditions that may also influence the health of the pregnancy are well controlled. So I think there are some things that we can do as clinicians, and that prospective parents can do in terms of engaging with their clinicians to try and reduce that likelihood. But having said that, there's certainly a lot, as Nadia said, that we don't understand about factors influencing preterm birth. And certainly we don't want parents to be feeling guilty about having had a preterm baby. I mean, when we talk about infection, these are generally not infections that anybody can do anything to prevent from a personal point of view, and that we really need to look at understanding the drivers of that, so that we can provide advice about treatments that do reduce the risk of prematurity.
Because when I was studying at uni, I was taught that, you were 2 to 3 times as likely to have another preterm birth if you'd had one. But I always worry that that's a very simplistic answer. But I don't know, Beena, you were taught the same?
I don't know if I was ever taught exact numbers, except that the risk was higher.
Yeah.
That is, it's fascinating. And I'm thinking about how every year around my birthday, my mom will start telling me my birth story, because it took, there were a few days, there was something that happened. I think she had a cold early in her pregnancy, and wondered if that, like when you say infection, it could be just that you had a cold or an ear infection or something that made your immune system like activate more than it normally would have. Is that what you're saying? Like when you say someone with an infection when they're pregnant, or is it like certain kinds of?
So look, it's very, that's it around the world. We would say something called chorioamnionitis. So that's an infection a woman will know about. Those are the kind of infections around, can also predispose to preterm labor. But actually one of the viruses we're looking a lot at, and I think we could talk again maybe in June this year when it's CMV month, about cytomegalovirus. We're realizing that this very common virus is probably a cause for a lot of preterm birth and stillbirth and cerebral palsy.
Wow. And
we're launching a big prevention campaign around that. So we, group B strep, could it be a cold? People get viral infections. We all get colds during the pregnancy. It's hard to pick out which one. It could be a cause of preterm birth, but then you got to look and think, well, those home isolation, not going to work, has decreased the rate of premature birth during COVID in some countries. So I think it's a really complex story, and probably got a lot of individual risk factors involved with that as well.
Right.
And it's really hard to stay at home if you're in a low-income country and isolate when you need to go out and work and put food on the table.
Yeah, like you said, there's just so many different interplaying factors, and there's no way to even name them all. Just with the small amount of time we have left, I wanted to see if each of you had a concluding thought that you wanted to share with people who are watching this and who will see this in the future.
I'm sure. I'm happy to go first. I guess what we know is that prematurity is really still a significant problem worldwide. It affects people of all socioeconomic groups in all countries, and is a significant contributor to both morbidity and mortality in children under 5 years of age. And I think that there are a number of things that we can do. I think education and looking at community initiatives, systemic and governmental level initiatives to try and improve some of the social contributors to prematurity. I think there's a lot of interesting and exciting research that is still ongoing in terms of reducing prematurity, ways to, when we know prematurity or preterm birth is likely, how can we optimize the health of the baby around the time of birth? And then what are the interventions and what are the supportive strategies that we use in the neonatal intensive care unit? And how can we better refine those to try and promote healthy brain development of the baby who is out in the world and was, supposed to have a number more of additional weeks in utero to develop as we usually expect to occur. And so how can we modify and learn and develop our treatment strategies to try to promote healthy brain development? And when we know that a child is at high risk of cerebral palsy, to harness some of those strategies we have for early detection and early intervention, and supporting babies to try and achieve whatever the potential that they have, to try and support families to have the best quality of life for their baby and their child in the future. And that is both in the NICU, but it's also in and around discharge and how we arrange their follow-up to support them into the future and even into adulthood.
Thank you.
I'm not sure there's much I can add to that. I will say that, we are very engaged in this immediate kangaroo mother care work at the AAP. We actually have a grant from the Gates Foundation towards advocacy of immediate kangaroo mother care. And maybe I'll just share a personal story related to that, in that there was a mother who at a recent town hall that we held at UCSF, who told the story about her first pregnancy, where she didn't really get to hold her baby at all. And in her second pregnancy, which was not a preterm birth, but a larger baby, but who had some respiratory distress, she was actually able to hold that baby for a few minutes before that baby had to go to the NICU. And just those few moments of being to hold that baby before the baby had to go and get other care in the NICU let her know that her baby was going to be okay. And so I think, just to emphasize one of Stephanie's points about really engaging families and seeing them as advocates for their babies and partners in their care, and recognizing that the role that they play in ensuring the best outcomes for their babies, I think is really important.
And for me, I would add that we need to do all of this in collaboration with families. I would love families to get trained in research strategies, tell us what matters, and get behind all of this work. I think that's the only way we're going to make huge changes.
Thank you. It's really about families being sort of the head of the team and picking their players. And the three of you are really important players for families to have. I appreciate your time. I appreciate the time of everyone who joined us here today. I hope you have a great rest of your day or night, no matter where you are in the world. Thanks again.